So we're joined by Dr. Liana Rood, a specialist breast and endocrine surgeon whose work bridges academic medicine, public sector advocacy, and integrative healing. She's the executive director of Project Flamingo, which improves equitable access to timely breast cancer surgery and holistic patient support across South Africa, and also serves as executive director of the Cancer Alliance, the leading civil society coalition driving cancer equity and policy reform. A lecturer at UCT's Department of Surgery, Dr. Rood is deeply committed to mentoring future surgeons and shaping a healthcare system where compassion and excellence go hand in hand. Her philosophy brings together science and soul, a belief that the best medicine is both evidence-based and deeply human. We are so happy that you're here with us today. Dr. Rood, I'm going to hand over to you.
Thank you so much for that very kind introduction. I'm very happy to be with you guys, and I hope we can have an interesting discussion today, and that it won't be the run-of-the-mill breast cancer awareness talks that you usually find rife in October, everybody pink everywhere. So talking a little bit about awareness, the importance thereof, but also what happens beyond the pink ribbon. So what happens if a diagnosis is actually made, because I think there's a lot of myths out there that needs to be debunked. And I think whether you're a patient or whether you are somebody that knows somebody, it's important for us to understand this topic a little bit more in depth. So I think this stat is well known everywhere. It's quite frightening. I think, you know, when people see this, they're quite overwhelmed, thinking that 1 in 8 women will face a breast cancer diagnosis in their lifetime. So it's a staggering statistic. And, you know, in fact, the World Health Organization indicates that not too far from now, this may even change into 1 in 7 women. These are first world statistics. Our South African statistics look a little bit different, but we do know that unfortunately our data capturing isn't as accurate. So there's a lot of diagnosed cases that goes unseen and uncharted in our country. But this is what we're dealing with. So if you look around you in the office or wherever you are, if you count 8 people, 1 in 8, that is, you know, it is quite something. The bottom line, and I think the message that's being driven throughout October is be your own breast friend. Really, really be aware of breast cancer as a disease. Be aware of your risk and go for your screening, because early detection saves lives. And all of that is true. And I'm going to talk to you a little bit about what you can do to be your own breast friend. But for me, from a bigger perspective, early detection only saves lives if the right treatment is available and if it's available in time. And that is something that I want all of us to understand a little bit more about what this treatment journey actually entails. So self-examination, I'm going to show you a little fun video. It may not be up everybody's alley, but how to actually do a breast self-examination. That is something that every woman can do for herself, and even partners can do for each other. That is the first step in awareness and early detection. So let's watch this video and let's see if this actually helps explain how you can do it in a fun way.
Hi, I'm Dr. Rutherford Gray, and it's come to my attention that many women aren't checking regularly for breast cancer. I'd love to discuss how we can change that. But since studies have shown that women are more likely to watch a video if it features a hot guy, I'm not going to. He is.
Hey, I'm Anthony, and I'm here to talk to you about Rethink Breast Cancer's Your Man Reminder. It's an app that gives you regular reminders to check your breasts from a hot guy of your choice.
Hey there. How you doing? Hey, baby.
It also shows you how to check yourself. Hello. A little something we like to call TLC. The T stands for touch. Start by touching your breasts in any way that feels comfortable for you. Try to be familiar with them and the way they feel. You know, you can do this anywhere, like on your bed, in the mirror, or even in the shower. Now the L in TLC stands for look. And for this one, you're going to need to use your eyes. Be on the lookout for anything unusual. And if you want to, have a friend check you out. And finally, the C in TLC stands for check. If you notice anything out of the ordinary, even if you're not sure, check with your doctor. Isn't that right, doctor?
That's right, Anthony. You see, TLC is a great way to help detect breast cancer early. Download Rethink Breast Cancer's Your Man Reminder app today. Now available for free in the App Store.
Okay, so hopefully that will help people remember. But it's really about getting to know your own breast, because breasts differ. They differ in size, they differ in shape, and they differ in consistency. So my advice to patients is always to pick the same day every month. For patients or women that are still getting their periods, the best time is usually about 4 or 5 days after your period ended, because the breasts are less tender and they are less dense and less nodular. Examine the breast every month around about the same time, even for postmenopausal women, so that you can notice a change. Changes can include anything from a lump to an increase in the size of the breast, or even shrinkage of the breast, dimpling of the skin, a change in the skin around the nipple, or a nipple discharge that comes out spontaneously, feeling a lump in your armpit that can be an indication of a swollen gland, and then dimpling or retraction of the nipple. So those are the signs, and I'm sure they are up everywhere and everybody should be aware of it. Now, I think it's quite important that we discuss a few hot topics. And that is the question around screening. So when we talk about screening, traditionally people don't think about a clinical breast examination. They think mammogram and they think ultrasound. And what's very interesting, that I think a lot of people that has got a private medical aid are not aware of, is that in South Africa, we actually don't have a national breast screening policy. So we don't have a policy that says if you're over the age of 40 or over the age of 50, you have to go for an annual mammogram every year. That does not exist. So we have a population-based clinical screening program. So that means that women need to examine themselves and women need to go for a regular clinical breast examination. People get quite riled up about it, but it makes sense in our setting because we've got such limited resources in our public healthcare sector, and we've got very uneven access to resources like mammography and ultrasound. If you look at the UK and if you look at Canada, they have also changed their screening policies. It used to be annual screening for all women over the age of 40, and that has been adjusted now to screen women between the ages of 50 and 70 every 2 to 3 years, focusing on quality and equity so that everybody can actually access these services. And Canada has changed to include, again, they've gone the other way, to include 40 to 70 years old and emphasizing informed choice. So both are trying to refine who will benefit most of regular screening. The bottom line is that why these changes have been made is that what we understand about breast cancer is that although the biggest risk factor for breast cancer is being a woman, there are other factors that also contribute to your risk. And if we do more focused risk-based screening, we actually pick up more cancers and we don't subject women to unnecessary screening. So how we assess risk is looking at a few factors, and there's actually some online calculators that anybody can use to help determine your lifetime risk to develop breast cancers. None of this is an exact science, but it does help us to be a little bit more specific in how we advise women. So we look at genetics, but it's very important to know that only about 5 to 10% of all breast cancers have a genetic link. So that's actually a really, really small percentage. I think as we learn more about genetics and we develop better genetic panels, we will likely discover more genes that has a breast cancer association. But at the moment, it's actually quite a small percentage. So what is very important then is to look at a patient's family history, and we look at all the cancers in the family, because we know that some cancers like prostate cancer or colon cancer can also have genes that may have an association with the development of breast cancer. So genetics and family history go hand in hand. The other things we look at is your exposure to estrogen, whether it is your own estrogen, we call that your estrogen window. So that is how young you were when you started getting your periods and when you went into menopause, as well as any exogenous hormone exposure. So whether you've taken oral contraception for very long periods of time without a break, whether you've undergone in vitro fertilization, several cycles, or whether you've been on hormone replacement therapy for a very long time. Breastfeeding is considered protective, and having children earlier in life is also considered protective. And then there's lifestyle, of course. And these are risk factors for all cancers, not just for breast cancer. It is diet, exercise, alcohol, sleep, and stress. Okay, so looking at all of this, putting it together for a patient, and then assessing their risk to advise them how often they should go for screening and how early they should start is what we want to look at. So the imaging toolbox usually consists out of a mammogram and an ultrasound. Those two are great partners. A mammogram is incredibly accurate in giving us early warning signs for breast cancer, and it really is the cornerstone of screening. And ultrasound forms the perfect partner to mammography, especially in women with dense breasts. So I always tell patients, you must think of a mammogram as a photo that you're taking in panoramic view. You can see the landscape, you can see a tree, you can see a hill, you can see something standing out, and then you can zoom in with the ultrasound to get more detail. We also use breast MRI, so that is the gold standard in terms of sensitivity, but it is an extremely expensive investigation, and it's definitely not for everybody. It is reserved for our very high-risk cases. So those are patients known with genetic mutations, patients with extremely dense breasts, or patients that's already had a breast cancer diagnosis previously. The other hot topic, and I've touched on it with risk factors, is the thing about breast cancer and hormone replacement therapy. Now, this is something that makes a lot of people incredibly nervous, and it all stems from the 2002 Women's Health Initiative study that created a lot of fear around hormone therapy, because analysis at that point showed that there is a high risk of the development of breast cancer in women that uses hormone replacement therapy. However, there were several problems with that study, and later reanalysis showed that the risk was mainly with patients that used a very high dose combination of estrogen and progesterone, and that estrogen only users actually have a lower breast cancer incidence. So it is important with all these things to remember that science evolve, and sometimes our public perception don't. So it is a conversation that you have to have with your healthcare practitioner. So we know that HRT is the most effective therapy for menopausal symptoms, and that these symptoms are a real threat to women's quality of life. It is also important for cardiac protection, for bone protection. So we are in an era where HRT is not just simply dismissed due to a irrational fear for the development of breast cancer. So for healthy women under the age of 60, or that has less than 10 years symptoms of menopause, the benefit actually far outweighs the risk. So have a conversation with your doctor and make sure that your decision is an informed decision, and that your whole risk profile has actually been considered when you talk about hormone replacement therapy. All right. Remember that the risk depends on the type of hormones that they use, how long you use the hormone for, how high the doses that you have, and of course what your personal and family risk profile is. So the take-home message with these two sort of controversial topics is that We must all remember that policies and evidence evolve and that context is incredibly important and that we are really functioning in an era of individualized medicine. So it's important to have open conversations with your doctors, ask informed questions, and remember that one rule does not apply to all. So access, education, and empowered choice is absolutely key. So the pink ribbon, October, it's just the beginning. It really is our depth of understanding of this message that matters. So this is why I thought it may be actually worthwhile spending some time explaining to people what a breast cancer journey involves and entails. Not only so that we have the information, but that should it happen to you or happen to a loved one or somebody you know how to best support this person. And I think, as you can see, it is a complex issue. There are many layers. There are so many opinions. And it makes it incredibly challenging and overwhelming for patients to distinguish what is fact, what is opinion, what may really be helpful and what may not. So usually how this journey starts is a patient presents with a breast lump or one of those changes that we previously discussed. Now, the way that we make a diagnosis, it's incredibly important to know that you can't use one of these things in isolation. We talk about the golden standard triple assessment. So you need all three of these things to make a breast cancer diagnosis. You need a good clinical assessment that includes your risk stratification that we've spoken about, your imaging, which is usually mammogram and ultrasound, and in select cases a breast MRI, and then a tissue diagnosis. Somebody needs to look under a microscope to actually determine whether this is a cancer or not. This breast cancer journey then starts with naming the cancer, staging the cancer. Very important that the diagnosis is actually discussed by a multidisciplinary team and that the treatment is not decided on by a single individual clinician. The treatment journey then starts, and then incredibly important is survivorship and what it entails. So the reason why I'm including this naming the cancer is people are always, well, breast cancer is breast cancer is breast cancer, and that is actually inaccurate. So I know this is quite academic, but I want people to really understand that you actually have many different types of breast cancer, and that is both on a histological, in a histological way. So that is where the cancer develops. So we can give it names. So there's just a bunch of names that you don't really have to know about. But what's even more interesting and much more important today is that we know that despite the name of the cancer, each breast cancer has a unique personality, and it's very important that we understand that personality. So this is the biological behavior of the cancer that is really driving how we treat and manage our patients these days. These are all academic things that you don't have to know anything about, but words that you may pick up when people start talking about their breast cancer diagnosis. So the way that I explain it to patients is I usually show them a family picture of quite a disjointed family. And we get Botas, the family name Botha, like breast cancer. The Botas from Benoni is not necessarily related to the Botas from Brakpan. So you get different personalities in different families, and that is exactly how breast cancer works. So each personality results in its own treatment. That is the timing of the treatment, the type of treatment, and the combination of treatment. And that combination can get quite complex. Surgery, endocrine therapy, chemotherapy, radiotherapy, immunotherapy, biological therapies, and all of these things get combined in different ways to form a treatment basket. So you can understand that this can be quite overwhelming to both patients and to their families. The staging is very important. So how far this breast cancer has actually progressed, and we do that with various investigations, CT scans, bone scans, because we want to understand whether we're actually dealing with a cancer that's only located in the breast or whether this cancer has already spread. And then what's very important is discussing this in a multidisciplinary team. Breast cancer should never be managed in isolation in today's age. So whenever you talk to somebody or you yourself is diagnosed with cancer, make sure that your team is a multidisciplinary team, that there's radiologists involved, pathologists involved, genetic counselors involved, breast surgeons involved, plastic surgeons involved, gynecologists, oncologists, nutritionists, dietitians, psychologists, etc. It is a whole team that looks after a patient. And that is quite reassuring to know that we don't make these decisions in isolation anymore. So treatment, like I say, we can get very technical about it, but it is very important to know that when we look at surgery, we used to be in an era where we did incredibly radical surgery, and a mastectomy or removal of the whole breast was the gold standard. We have moved away from that completely. And the key with breast cancer in 2025 is de-escalation as far as possible. There is massive studies that has proven that more radical surgery does not necessarily result in better outcomes. So if a patient or a family member tells you that my doctor is only going to do a lumpectomy, that is actually evidence-based and it's accurate and it is safe. So just again, evolving your understanding of the disease and what is available to treat it. The same goes for our chemotherapy drugs, our endocrine therapy drugs, the types of radiation that we can give, and then very exciting is our new drugs, our biologicals and our immunotherapies that's far more available. Then incredibly important, and I think in the workplace, with friends, with family, with loved ones, is to understand survivorship and follow-up. And funnily enough, this is often the hardest part of the journey for patients. Coming through the treatment, everybody is brave, they are busy, they are in survival mode. But once they get the all clear and now we are just following up, that is when the fear really sets in and where the hard work begins. Survivorship entails so much because we have to understand that each patient has his or her, remember men can also get breast cancer, own coping strategies that needs to be understood by the people that surround that person. The treatment that we offer patients, unfortunately, does impact on their sexual health, on their relationships, on they have various side effects that they have to deal with. We have to encourage very important lifestyle changes. It has a ripple effect on the entire ecosystem. And then there's this thing, I call it the psychology of dread, where patients go into what if this happens again? What if it comes back? And how they deal with this sort of constant companion that is now part of their story. And this is where people become really fearful and they don't want to talk about breast cancer because they remember that statistic and they're like, what if I become a patient? And I think my message really is for everybody just to take a deep breath. Breast cancer is the most common cancer, but it also means that it is the most researched cancer. And we have come leaps and bounds in what we can offer in terms of treatment for this disease. It is not a death sentence. It doesn't have to be one. And it can also present an opportunity for healing, okay, to make whole what was broken far beyond your cancer. So I always talk about the 5 pillars of healing with my patients that for me goes way beyond surgery, way beyond the chemotherapy room. And that is looking at what is happening in our socio-emotional environment. Can we optimize our own cellular environment with diet, exercise, etc.? What is the medicine that we are going to do? How can we get our house in order? And that I mean everything. You know, where are those things? Is this an opportunity to actually fix things that we've just left, put in a closet and don't want to look at? And that goes along with a psycho-spiritual journey that can be quite enriching and really a cornerstone of healing for a lot of patients. And if we look at the integrative medicine principles that we would like to follow and combine with our traditional methods of healing in breast cancer, we look at what we call radical remission strategies. We look at diet, there's not one specific diet, but usually mindful eating, learning what works with your body, what helps with your side effects, and just improving, all the things that we know, all the greens, all the good stuff. Taking control of your health. So really tapping into your inner physician. And this is where this education part for me is so important, and why I've spoken to you guys about actually quite technical stuff, because information is power, taking control of your own health, asking the right questions, and demanding excellence from your treatment team. While you follow and trust your own intuition, use certain supplements, release suppressed emotions, increase positive emotion, embrace social support, and you'd be surprised how difficult this can be for cancer patients to actually admit that they need help. And this is maybe the first time in their life where they have to say, I can't do this on my own. I need help and I need support. Very often, it goes along with a deepening of some sort of spiritual connection for patients. That seems very helpful. Having a really strong reason for living that keeps them motivated. And very often, if they approach this very hard journey with all of these factors in mind, they very often receive the gift of healing, not just cure, because there's actually a difference. Healing represents an expansion of consciousness and a movement in the direction of wholeness and health. And this is a bit of a mind twist for a lot of people, but it is so true. We can be healed by our illness, even if we're not cured of it. And then the flip side, and I think this is where we miss the gift and we get obsessed with treatments and being right, is where we can actually be cured and we miss the healing. So for me, it is about really, really embracing the healing journey that entails all of these things, and knowing and holding on to the fact that it really, really is possible for our breast cancer patients. So just a little bit about Project Flamingo, since I was introduced so nicely in that context as well. All of these things that we've spoken about, I think you realize that awareness is one thing, early detection is one thing, but it is so important that patients can access timely, evidence-based and dignified care. And unfortunately in South Africa, that is not possible for everybody. If you are dependent on the public healthcare sector, you unfortunately will face incredible delays in all these steps. And it is the work of Project Flamingo to really shorten those waiting times. We work on the ground in the coal face to reduce the waiting times for patients to get their treatment, whether it is surgery, whether it is chemotherapy, but to make sure that everybody can have a dignified and a healing journey through breast cancer. Sorry, guys. There we go. So, and that is it. I think I've given you quite an information overload, but
Thanks,
it's half an
Dr.
hour.
Thanks, Dr. Ritt. Really, really appreciate your time, and to everyone that has joined us. If we can just take a minute to answer a couple of questions, those that can stay on, please do. I am also going to be posting a form in the chat over here. We'd love to hear from you, any feedback that you've got. So 2 questions that came out of the chat today is if you would be able to touch a little bit on male breast cancer. And then the second thing is also in terms of being a supporter of someone that is, going through this journey, what do you think is, the most meaningful way that as a supporter you can help that person on their journey?
Okay, it's 2 great questions. So yes, men can get breast cancer, and I think it's very important that we actually highlight that fact. It is far less common in men. So if we look at the 1 in 8 statistic with women, the stats for men at the moment is 1 in 100. So still fairly common, but much less common than in women. And very often male breast cancer is associated with our genetic mutations. So the most common ones we know of is your BRCA gene mutations, BRCA1 and 2. A lot of people know it as the Angelina Jolie gene, where she went and she had her prophylactic mastectomies done. So when we see breast cancer in men, we immediately investigate further to see if we can identify a genetic predisposition for it. The presentation is exactly the same as in women. So men would present with a breast lump, they would present with skin changes, nipple retraction, exactly the same signs and symptoms in men, and very important that it's not ignored just because you are a man. It's the same. And then in terms of support, so I think most patients will tell you, especially in the beginning phases of a diagnosis, is to be present. And to be present kindly, and to, at least in the beginning, hold your opinions for yourself, because they are quite overwhelmed by a lot of opinions already. Just because, like I've explained to you, there's so many nuances. Just because your neighbor's auntie's sister had breast cancer and had that treatment, don't overwhelm patients immediately with what you think or what you've experienced, or, I think that really throws the apple cart. In fact, I tell my patients for the first month they must develop selective hearing. So be careful with what you say. Kindness goes a long way, and just being present to allow that patient to express his or her own feelings. And then in terms of support, actual support, it's the practical things that makes the biggest difference. For a woman especially, that's mom, that's working, that needs to look after the house, do a load of washing, bring some meals, offer to drop the kids, accompany her to doctor's appointments, put together a care package. Chemotherapy takes long, 4 or 5 hours in the chemo chair. You get bored. You need something to distract you. So there are so many small ways in which people can be supported.
Thanks, Dr. Rudd. Do you have time for one more question?
Yes, no, go for
thank
it.
you so much. Can someone get breast cancer during breastfeeding?
Yes, you can. So I think this is the other thing, and I didn't include it here. So breast cancer is more common with age. So the older you get, the higher your risk. But we are seeing a trend that we are diagnosing women earlier and earlier. My youngest patient is 21 years old. So breast cancer does not discriminate in terms of age. If you're a woman, you can get breast cancer, or a man for that matter. So, and with breastfeeding and pregnancy, there's obviously a surge in hormones, and especially for our hormone-driven breast cancers, it can add as fuel to the fire. So no new lumps should be ignored, even if you're breastfeeding. Get it checked out, ask your clinician about it. Very important.
Okay, perfect. Thank you so much, Dr. Rudd, for your time this morning. Really appreciate it. And yeah, it's been absolutely amazing. And thank you so much for advocating for us. It's really appreciated. Okay, and thanks to everyone who joined. Really, appreciate your time today.
Thank you so much, Michelle.
Thank you so much, everyone. Thanks, Dr. Rudd. Bye.
Thanks. Bye.